Bismillah ar-Rahman ar-Rahim. Good morning, everybody. I'm Professor Dr. Doaa Elsalamawy. Our lecture today about central nervous system infection. Our objective to detect early meningitis, differentiate between different types of meningitis, investigate a case of meningitis and encephalitis, know how to treat and prevent serious complications. Let us to see the first case. A 28-year-old man present to emergency room with a 48 hours complaint of headache. The headache is primarily in the frontal and occipital region and associated with mild nausea. 48 hours headache and nausea. Headache has taken various analgesics without any improvement, so severe with no improvement with analgesics. The intensity of headache has gradually increased since it began promoting evaluation, as he was no longer able to tolerate it. So severe headache, not responding to any analgesics, and is crescendo in character. His only other symptom beside nausea, tightness in the shoulder and neck. He is not known to have any medical illness before or head trauma. On examination, his temperature is 40, blood pressure 110/68 mm mercury, pulse 110 beats per minute. He is awake and alert, fully oriented. However, he feels is taking so much time to answer questions. In other words, bradyphrenia or slow mentation. His general examination is notable for the finding of a chronic sign positive without evidence of any skin rash. Brudzinski sign is present. Cranial nerves are normal except for bilateral horizontal nystagmus. His motor, sensory, cerebellar examination are normal. Deep tendon reflex shows generalized hyperreflexia with evidence of a positive Babinski sign. CT scan of the head is performed without contrast, which is read as normal. Importantly, his headache is worse now than what it was when it is present in emergency room. Still, the headache is so severe. Here is the questions. What is the most likely diagnosis? What is the best diagnostic next step? What is the next step in therapy? The presentation of crescendo headache, increasing headache associated with nausea, fever, slow mentation, alert the clinician of meningitis or meningoencephalitis. It is also suspected if the patient presents with triad of headache, fever, disturbed level of consciousness, the presence of neck tightness, positive chronic sign is consistent with meningitis rather than encephalitis. The presence of signs of meningeal irritation raise the possibility of meningitis rather than encephalitis. Of course, lumbar puncture or CSF study is the next step, and it is the best way to determine etiology of meningitis, allowing one to distinguish between bacterial, virus, or so on. Although CSF studies are key to identifying meningitis, an imaging study with either CT or preferably MRI brain scan with a contrast is preferably done prior to spinal tap to exclude the presence of increased intracranial pressure. MRI brain scan offers better resolution than CT, but it may not always be readily available. The importance of imaging study is to help exclude increased intracranial pressure caused by impaired CSF drainage or the presence of space-occupying lesion. Of course, if we do spinal tap in cases of severe increased intracranial pressure, high possibility of cerebral herniation and death of the patient. So, the presence of focal neurological deficit in the presence of papilledema mandate imaging study. Once it is determined that the risk of herniation is low, lumbar puncture is performed. Lumbar puncture analysis should include opening and closing pressure, physical examination, chemical examination, cytological examination, and finally culture sensitivity and PCR if possible. Meningitis and encephalitis are diffuse infection of central nervous system. Meningitis is primary involvement of meninges, whereas encephalitis indicate brain parenchymal involvement. Because these anatomic boundaries are often not distinct, many patients have evidence of both meningitis and parenchymal involvement, so we call it meningoencephalitis. Bacterial infection in cases of meningitis could be bacterial meningitis, tuberculous meningitis. Other CNS infection could be viral meningitis, herpes simplex encephalitis, fungal infection like cryptococcal meningitis. Meningitis could be acute bacterial meningitis, tuberculous meningitis, aseptic meningitis. First, acute bacterial meningitis or biogenic meningitis or septic meningitis. Okay, the most important topic today. What about epidemiology of bacterial meningitis? Regarding incidence, 5 to 10 cases every 100,000 population. 6, male, generally more affected than female. Regarding age, according to causative organisms, H. influenza between 3 months and 7 years. Pneumococcal infection could occur in children and adults. Meningococcal meningitis could occur also in children and adults, and rarely above the age of 50. A season usually in winter, spring, and falls. Of course, streptococcal pneumonia, Neisseria meningitidis, and H. influenza are the most common cause and responsible for about 80% of bacterial meningitis. What about other bacteria? Enterobacteriaceae like E. coli, specifically in newborn infant after delivery, when there is a vaginal contamination or urinary tract infection of the mother, the baby or the newborn may catch E. coli infection causing meningitis. Other bacteria like Pseudomonas, Proteus vulgaris, Klebsiella, usually occurring in immune-compromised patient, debilitating patient, cancer patient, and so on. Also group B, Streptococci, Staphylococcal aureus, Listeria, monocytogenes. These microorganisms usually occurring in debilitating patient and immune-compromised patient. What about route of entry? The most important route of entry is upper respiratory droplet infection. Hematogenous spread, extension from adjacent structures like sinusitis, mastoiditis, ear infection, penetrating wound, iatrogenic during lumbar puncture, during brain surgery. What about the clinical picture of meningitis? Of course, as I said before, fever, irritability, lethargy, disturbed level of sensorium, headache, vomiting, blurring of vision, photophobia. Signs of meningeal irritation like neck rigidity when asking the patient to bring his chin on the anterior chest wall, he can't do it. Neck rigidity, okay? Positive Koenig sign, positive Brzezinski sign. What about Brzezinski sign? Either neck to leg or leg to leg. Neck to leg, passive flexion of the neck, the patient automatically flex both hips and both knees. This is passive neck flexion. Brzezinski sign, neck to leg. Brzezinski sign, leg to leg, passive lower limb flexion, automatically the other lower limb, hip and knee will flex. Koenig sign. What about Koenig sign? When the patient in supine position and his hip at 90 degree, try to extend the leg. There is severe stiffness of hamstring muscles, causing inability to straighten the leg when the hip is flexed 90 degree. Of course, convulsions. Convulsions can occur specifically in infant and young. Disturbed state of consciousness, drowsiness, confusion, delirium, stupor, or even coma. Purpuric rash, specifically in case of meningococcal meningitis, there is purpuric spots, petechial hemorrhage, and ecchymosis. In infant and neonates, headache is not described, and meningeal signs appear and might not be evident in infant. Okay? The headache sometimes is so severe, causing what we call meningitic cry, with a high resonance speech cry, specifically in young children. In neonates, we find bulging of fontanelles and sutures. In neglected or maltreated patient, complications, serious complications might develop, might be a focal neurological deficit due to thought paralysis, due to focal collection of exudates, or even brain abscess with a central core of liquefactive necrosis surrounding encephalitic zone and wall. That is to say, formation of brain abscess. Vascular occlusion with vasculitis causing infarction and cranial nerves involvement. In severe condition, leading to circulatory collapse and syndrome of inappropriate secretion of antidiuretic hormones. Hydrocephalus, either communicating or non-communicating due to fibrosis and gliosis of a CSF pathway. Subdural empyema with collection of pus in subdural space and massive septation in the subdural space. All these complications are fatal complications. The most important investigation is lumbar puncture. Of course, lumbar tab is very important. And after doing lumbar puncture, we can give antibiotic blindly. Not delay to the results of a culture and sensitivity. Again, we do lumbar puncture. If there is no contraindication of doing lumbar puncture, send to lab for physical examination, cytological examination, chemical examination, and culture sensitivity, and hence give antibiotic blindly after doing spinal tape. CT or even MRI doing if I'm suspecting signs of lateralization, the presence of focal neurological deficit or deterioration of level of consciousness. There is a contraindication of lumbar puncture, like the manifestations of increased intracranial pressure, like possible herniation or third pupillary response with a new focal neurological deficit. I must do CT first. Second, local skin infection like carbuncle over the back. If presence of local skin infection, it is contraindicated to do lumbar puncture. CSF analysis, of course, under massive increased pressure. Physically, the color is turbid. Normal CSF is crystal clear. Crystal clear, more clear than water. Okay, here it is turbid, sometimes yellowish, okay, in color, with increasing cells, usually up to 1,000, 10,000 per DL, mainly neutrophils or pus cells. The cells mainly in cases of biogenic bacterial infection, mainly neutrophils, polymorph, white blood cells, polymorph, okay, with increased protein, usually above 45 milligram per DL, from 100 to 500 milligram per DL. Decrease sugar, of course, bacteria consuming sugar less than 40 milligram per DL or less than 40% of blood sugar. Then we do either gram stain or culture sensitivity. Is must do it. Culture sensitivity in order to give proper antibiotic. Radiological investigations, either CT or MRI brain in case of lateralization or suspicious of increasing intracranial pressure. Regarding the treatment of bacterial meningitis, of course, there is a general principle. First, hospitalization, isolation, of course, it is infectious disease. The minimum duration of antibiotic therapy, at least 10 days from the start to the patient become afebrile. Then continue 7 days after the patient become afebrile. Okay? If the patient after 10 days still feverish, that is to say there is mistreatment, under treatment, improper dose or improper antibiotic, improper choice of antibiotic, not crossing blood-brain barrier. So I'm expecting, if I give the patient proper antibiotic with proper therapeutic days, after 10 days the patient become afebrile, then continue 7 days after the patient become afebrile to ensure killing of all microorganisms and not to develop resistant strain. We recommend empirical antibiotic for suspecting bacterial meningitis, vancomycin plus ceftriaxone by anti-meningitic dose. Of course, the dose completely differ than any infection. I'm expecting to give double or triple the dose of any infection. For example, I give ceftriaxone average adult daily dose 4 grams per day. Of course, if we treat chest infection, we give 1.5 grams per day. But here up to 4 grams per day. Vancomycin up to 3 grams per day. Of course, the dose is completely different because I give a mega dose to ensure it is crossed the blood-brain barrier. Until the results of a culture sensitivity, if culture sensitivity matching with this empiric antibiotic, continue. If it is not matching with this empirical antibiotic, correct the antibiotic. Corticosteroid like dexamethasone decrease mortality and decrease sequelae. Of course, corticosteroid under umbrella of antibiotic, it minimized gliosis and fibrosis, and it minimized the occurrence of hydrocephalus. Again, empirical treatment should be given until the results of CSF culture sensitivity is available, and then give specific antibiotic according to the culture and sensitivity. What about prevention? Of course, for contact, give chemoprophylaxis. For adult, we give ciprofloxacin about 500 milligram single dose. In children, we give either cefotriaxone intramuscular or 4 doses of rifampicin. Vaccination, of course, available, obligatory polysaccharide polyvalent vaccine against meningococcal meningitis in school-age children. It is obligatory nowadays. Tuberculous meningitis. Second topic today is tuberculous meningitis. The incidence of tuberculous meningitis nowadays is increasingly since 1985. This related mainly to increase the incidence of AIDS virus. Of course, in Egypt, shisha smoking might transmit Mycobacterium tuberculosis. Clinical picture: headache, lethargy, vomiting, meningeal signs, seizures. Unlike other bacterial meningitis, TB meningitis characterized by, of course, the presence of TB toxemia with loss of weight, night sweating, anorexia. Less rapid onset over 1 or 2 weeks. It is subacute, not so acute like biogenic infection. More frequent involvement of cranial nerves, specifically 3rd, 4th, 6th cranial nerve, orthofacial nerve, auditory nerve could be affected. 8th cranial nerve could be affected with the course of tuberculous meningitis. Focal neurological deficit are more common due to the presence of tuberculomas, presence of granuloma. Only 2/3 of the patients with tuberculous meningitis have evidence of pulmonary TB. So if you find the patient with clear lungs, it is not exclude the presence of TB meningitis. The patient with tuberculous meningitis, if left untreated or undiagnosed, progressive deterioration of consciousness, stupor, coma, mortality in undiagnosed cases up to 100% of cases. Of course, CSF analysis is the most important with increased pressure. The color is either ground glass opacity, it is ground glass opacity, or sometimes we described as cobweb opacity and the presence of thread inside the CSF. Increased cells, mainly lymphocytes, increased protein, high protein, more than 500 milligram per GL, decreased sugar, Mycobacterium tuberculosis consumed sugar, so it is decreased. Decreased chloride, very important, we find chloride decreased. Of course, Zell-Nielsen stain, culture for Mycobacterium tuberculosis, and PCR polymerase chain reaction for Mycobacterium tuberculosis DNA. CT and MRI imaging showing focal neurological granulomas or tuberculomas, okay, with vasculitic processes and end arthritis obliterans and caseation, forming tuberculoma, multiple tuberculomas. Hydrocephalus common with tuberculous meningitis due to excessive adhesions in CSF pathway. Of course, other like CBC, serum electrolytes, renal function test might be disturbed in case of tuberculosis. What about treatment of tuberculosis? Of course, we give first 2 months 4 drugs, 4 anti-tuberculous drugs like rifampicin, isoniazid, pyrazinamide, and ethambutol for 2 months, followed by from 10 to 12 months continuation with 2 drugs. Usually we use rifampicin plus isoniazid. Take care, give vitamin B with isoniazid to prevent the occurrence of peripheral neuropathy with isoniazid. Adjuvant corticosteroid appear to improve survival, of course, under umbrella of anti-tuberculous medication. Third topic in our lecture, aseptic meningitis. What is meant by aseptic meningitis? Used to describe syndrome with the following criteria: acute onset of meningeal symptoms and sign, CSF suggestive of meningitis, showing a small or large number of cells, mainly mononuclear cells or lymphocytes. Never polymorph, mainly mononuclear or lymphocytes. Increased protein, normal sugar. The sugar is normal due to no bacteria consuming sugar. So we find mainly lymphocytes or mononuclear leukocytes, increased protein with a normal sugar. Absence of bacteria, and the results of culture sensitivity is negative, no bacteria. This is relatively short duration and benign course. Finally, encephalitis. Encephalitis is an inflammation of brain parenchyma, which is often a result of unusual complication from viral infection. The most common viral encephalitis is herpes simplex encephalitis, specifically type 1. Many other viruses can cause encephalitis, like Epstein-Barr virus, other than herpes simplex virus, Epstein-Barr virus, cytomegalovirus, measles virus, chickenpox virus, and rabies virus. Don't forget rabies virus, which results from domestic animals like dogs and cats and so on. Herpes simplex encephalitis, the most and gravest form of acute encephalitis. It is fatal in 30 to 70% of cases. That's important to diagnose early herpes simplex encephalitis. The fatality about 30 to 70% of cases, and most survival have sequelae. It is due to herpes simplex type 1. This is the most common viral encephalitis. The brain gets affected via either local spread from oropharyngeal infection, oral or oropharyngeal herpes simplex virus, and reach the brain via trigeminal or olfactory nerves. Second, possible viremia, but the main through trigeminal or olfactory nerves from the oropharyngeal infection. What about the clinical picture? Acute onset of headache, fever, confusion, delirium, stupor, may proceed to coma, disturbed sensorium, headache, fever, okay, and sometimes massive edema of the temporal lobe result in brain herniation or uncal herniation. Manifestations of temporal lobe insult, including complex partial seizures or temporal lobe epilepsy, psychotic or behavioral changes, olfactory, gustatory hallucinations, dysphagia, or even complete aphasia if it affecting the dominant hemisphere. Hemiplegia sometimes occur, memory changes, which is usually late manifestations. Regarding investigations, of course, CSF is important, increasing pressure, increasing protein, increasing cells, mainly lymphocytes, normal sugar with positive PCR, herpes simplex virus DNA positive or PCR positive, polymerase chain reaction test positive, and this is diagnostic of choice in cases of herpes simplex encephalitis. CT or preferably MRI brain, characteristically the lesion in the inferior and medial portion of temporal lobe with scattered areas of hemorrhages and surrounding edema. EEG also diagnostic, showing periodic high voltage sharp waves and slow wave complexes, mainly in the temporal area. This is picture showing MRI brain T2 sequence with a temporal lobe lesion. This is the area of inflammation, okay, and the scattered area of hemorrhages with a surrounding edema, mainly in the temporal lobe. Again, this is temporal lobe, comparing this normal temporal lobe and the other temporal lobe, showing massive edema, and it is voluminous with the scattered areas of hemorrhages. Okay, this is a picture showing EEG in cases of herpes simplex encephalitis with periodic complexes of high voltage, sharp wave, and slow wave complexes, mainly in the temporal area, periodic discharge. Regarding the treatment of herpes simplex encephalitis, intravenous acyclovir or Zovirax in a dose of 10 milligram per kg per dose. The number of dose is 3 times per day, or we calculate the dose like 10 milligram per kg every 8 hours for 2 weeks. Of course, corticosteroid may used in cases of brain edema. This is a second case for testing yourself. If you want anyone to discuss this case with me, I'm ready and welcome for any student. And thank you.